Okay, and I'm bringing on Dr. Roshon, and I'm going to stop screen share for just a moment, but I'm going to introduce him first. In 2020, the COVID-19 pandemic upended business as usual for bike clubs throughout the US. Faced with ever-changing conditions and information, clubs have struggled to maintain that balance of safety and our strong desire to ride. USA Cycling's Dr. Michael Roshon provides an update on where we are now and how to mitigate risks going forward. He's the Chief Medical Officer for USA Cycling, as I said, and previously for several professional cycling teams. Michael is also the Chief of the medical staff for a large hospital system in Colorado Springs, Colorado. So I'm going to stop screen sharing. And so you should be seeing Michael. Go ahead and take it away.
Kevin, how are you?
I'm doing great. We also have a poll, as Michael, you and I discussed. So whenever you want to launch that, just say the word. If you're just joining us, questions in the chat box. You're probably reading everything that I say transcribed. If you want to turn that off, it's easy to hide. Yeah, and all of this will be recorded for later.
Excellent. Hey, thank you so much for the introduction. And Kevin, if you can just track along, and when it's time for a poll, maybe let me know. Thanks to everyone for joining. I am the Chief Medical Officer for USA Cycling, but my day job, I'm an emergency physician here in Colorado Springs. And as the Chief of the medical staff, I was our lead medical expert on our COVID task force, trying to figure out how we would respond to this pandemic and try to keep the entire medical staff up to date. So I have really spent a lot of time this year keeping up to the minute on the latest COVID research and our understanding. And when I think about what's happened this year, there's a lot of fear and uncertainty around this virus and how it affects people. And I think the best way to deal with that is to understand it. And so I'm going to get a little bit sciencey, if that's okay with you guys, if sciencey is a real word. And my goal is to understand really what we know about this virus, and then use that to inform how we can do safe cycling in this environment. And I want to explain how that knowledge and understanding went into our sort of COVID protocols and our guidance that we have for putting together events and things like that. So I am going to share my screen, and you can see all of my slides. So naturally, you always have to start any COVID talk with a very scary picture of the coronavirus. So there it is. And let's get going. So everybody can see my screen? We're good? Excellent. So this is what we'll talk about. We'll talk about COVID-19, a little bit of the science behind it, and how that informs what we think we can do for cycling. Okay, so sorry, a little bit of a pause there. All right. Here's the basic agenda. I want to go through some COVID basics. Talk a lot about transmission, because that's mostly what we're concerned about when we're talking about how we can put on safe events and safe races. And then I want to get into, once we understand how the virus is transmitted, how can we mitigate that transmission? I do want to spend a little bit of time talking about the vaccine, and that's going to mean talking a little bit about the variants. And then we'll use all of that info to talk about cycling in the COVID era. And my goal is to leave plenty of time for discussion. So we'll see how I do. Okay, really basic. This is the sciencey part. It's only one slide, so stick with me, okay? The way the virus is made is it's got an RNA genome that encodes all of the genes that the virus needs, and that's wrapped in this thing that's surrounded by this spike protein. That spike protein is what binds to the receptor on your cells if you're unlucky enough to get it, and think about this as lung cells. It binds to that receptor, the virus gets into the cell, and then it basically hijacks your cellular machinery to make copies of itself. So it doesn't have the ability to copy itself, but it uses your cellular machinery to do that. And here is a look at a human lung cell that is infected with the coronavirus. And you can see all of these little round circles. Those are millions and millions of copies of the coronavirus. And they're actually budding out of the cell. And if you think about this like a lung cell, now that's in the airway. When you cough or sneeze, then you can expel those viruses and they can go infect someone else. So what happens when the virus takes over is it can actually kill those cells, and that's what causes so much problem for people when they get this virus. So how is it transmitted? If somebody has the infection and then they're coughing or sneezing, it's a really key thing to try to understand, because if we can understand how it's transmitted, we can understand how to stop it. And we're used to this, right? Because it's transmitted very similar to the way influenza is transmitted every year. Most viral respiratory infections can be transmitted either by contact, so direct contact with a patient who's infected, by droplets that are coughed or sneezed out, or through the air. And those droplets typically don't go more than about 6 feet. So that is really key. Airborne transmission is driven by the droplet size. If they're tiny little droplets that actually float in the air and don't fall down, then they can spread through the air. And we have a lot of examples of naturally occurring airborne viruses, things like chickenpox, smallpox, or measles. These are ones where if there's anyone in the room that has measles and somebody is not immune, hasn't been vaccinated or whatever, then they're going to get it. The best way to understand that transmission and how that leads to a pandemic where the entire world is now shut down because of this is to think about what's called the reproduction number, or what's called the R naught. And it's a very simple concept. It's the average number of people that are infected by one sick person. If that number is greater than 1, if I have it and I spread it to 1.5 people, then the transmission is just going to spread across the entire globe. We see that every year with influenza, right? It typically starts in Asia, spreads across the globe, and we see millions and millions of cases of influenza every year. There are a couple of features of SARS-CoV-2. So again, that reproduction number, if it's greater than 1, the virus is going to spread. If it's less than 1, then it's not going to spread across the globe like that. SARS-CoV-2, it's a virus that causes COVID-19, has a couple of features that really contribute to it spreading so quickly. Number one, they're asymptomatic carriers. So these are people that don't even know they're sick, but they're able to spread the virus. And then there are pre-symptomatic carriers. So even for the people who are going to get sick and they're going to get a cough and they're going to get a fever, they can still start to spread in that 1 or 2 days before they even know they're sick. And then the big difference here is there's very high susceptibility. This is a brand new virus. Last January, nobody had any immunity to it. So anyone that was exposed was quite likely to get infected. So those 3 things, asymptomatic, pre-symptomatic, and that very high susceptibility, are what's fueling this pandemic. If we look at COVID-19 or SARS-CoV-2 compared to some other known, infectious diseases, what we have here is on this y-axis, there's mortality or the fatality rate, and on the x-axis, there's that R naught, or that transmission. How many people does one infected person transmit the virus to? And you can see things like measles, the R naught is really high. It's over 15. And chickenpox, also very high, but the mortality is really low. Here's where we are with COVID-19. The R naught is around 2.4 when it first came out, so really, really spreading quickly. And the mortality rate was definitely higher than the common cold or flu, or the typical seasonal flu, but not as high as some other bad viruses like Ebola or the original coronavirus, SARS or MERS. So the key thing I want us to understand is that R naught, if it's at 2.4, it's going to spread all over the place, and we've seen that. But that transmissibility is not intrinsic to the virus. It's a combination of what the virus is like and what we do to stop the spread. So we've seen at different times during this pandemic that R naught fall to well below 1, and you see the number of cases go down. So we can, by understanding how it's transmitted, we can affect it. As long as that R naught is greater than 1, it's gonna spread. So here's the spread if the R naught is a number as low as 1.1. If it's 1 or if it's less than 1, you can see how that affects it. And again, for COVID-19, when it first came out, the R naught was 2.4, so it was spreading like crazy, and that's what we saw. So how does it spread? We know now, we didn't know this last January. There was a whole lot of uncertainty, but now we know pretty clearly it spread almost exclusively by droplet and contact. This seems to account for the vast majority of infections. We worried, could it spread from surfaces? And there were some early papers that showed that it could survive on surfaces, but that does not seem to be driving a lot of the infections. So droplet and contact, that really close contact within 6 feet is what seems to be causing the majority of spread. We also worried, could it be spread in food? Again, it does not seem, we know there are cases where that might happen, but it seems to be very rare, and that does not seem to be fueling the pandemic. And then there's a lot of concern about possible airborne spread. And again, if this thing spread like measles, we would not be talking about trying to do bike races or events, because it would just be too dangerous. So the World Health Organization says they don't see any evidence of airborne transmission, and they favor primarily droplet and close contact spread. CDC says we think that airborne spread is possible in certain conditions, but again, doesn't seem to be the main way it spread. And those certain conditions are areas of poor ventilation and prolonged contact. So that is key. So when we're talking about how we're going to stop the spread, we need to concentrate mostly on droplet and contact, but keep a little bit of an eye out for possible airborne spread. Let me give you a couple of real world examples of this. So these are actual case reports where very careful contact tracing was done to try to understand how an outbreak happened. The first one is a flight. It was about a 5-hour flight. There were 325 passengers on this flight. And one patient got on the flight and essentially became symptomatic with a fever and a cough during this 5-hour flight, and spread COVID-19 to 11 other patients on that flight. All 11 were unmasked, and it's important to know that the index case, the initial patient, was unmasked as well. They were unmasked, and they were all very close. So 1 row behind or up to 2 rows in front of this person. None of the flight attendants were infected, and they were all wearing masks. So again, that tells us that in this case, it seems like the transmission was done via close contact. They had to be within a row or 2 of this patient. And I don't know about you, but can anyone imagine getting on a plane with somebody who's got a fever and a cough and is not wearing a mask right now? I mean, this was very early on. We didn't really know what we were doing. So again, this just goes to say that the vast majority of transmission seems to be droplet and close contact. One more example from a flight. I'm not trying to scare anyone from traveling, but it's just a really sort of closed situation to be able to really understand what happened. In this case, there are 335 passengers on a flight from Singapore to China. There were actually 16 patients on this flight that were positive. Nobody knew it, of course, but they were all quarantined and tested when they arrived in China, and they found 16 people were positive. And there was only 1 case of a transmission on the plane. And that was an unmasked person who was sitting very close to 4 other positive patients. So it seems that he got it from one of those patients. So again, very close contact, does not seem to be spreading through the air, but mostly that droplet and close contact. And that's key for us. So when we look at the initial spread of this virus so quickly, globally, it's a pretty terrifying map to watch it spread so quickly. And that initial reproduction number was 2.4, which means it's going to spread very, very quickly. But we know now from over a year of experience for this that there is this weird paradox where we know that 70% of people don't transmit the virus at all. So their reproduction number would be 0. So up to 70% of people don't give the virus to anyone. And the attack rate, even among close family contacts, so if someone in the house has it, it is still only around 15 to 20%. So it is very unusual. And it seems to be that these super spreader events are what's really fueling the thing. So I don't know about any of you, but I've seen many cases where a husband got the virus and nobody else in the family did, or the wife got the virus, or one of the kids got the virus and didn't spread it to anyone. That tells me that we can control the spread of this virus by doing a few simple things. And again, what we want to do is get that R naught to less than 1, and that will control the spread. If we do nothing, then this is what it looks like, right? 113. This is just a screenshot from the Hopkins University COVID tracker yesterday. 113 million cases globally, with over 2.5 million deaths. And if you look down here, you can see this is the case count per day, with about 400,000 cases per day globally still. U.S. unfortunately is winning this race with 28.5 million cases in the U.S. With that kind of spread, our goal with controlling the virus and controlling the transmission was really to prevent the healthcare system from getting overwhelmed. And what we saw early on in Italy, in Seattle, and in New York is that the spread happened so fast and so many people came to the hospital that they really overwhelmed the healthcare system. And then we saw very high mortality rates from those outbreaks. Rather than letting the healthcare system get overwhelmed, measures were put into place to control the spread so that we could keep that capacity. That is the flattening the curve concept that you've heard so much about, and that we have been at various times very successful at, and at other times not so successful. What we're all trying to avoid is what has happened recently in California, where the ambulance system got overwhelmed, hospitals were overwhelmed, and they honestly couldn't take care of people. They wouldn't even transport people to the hospital because there was no way to care for them. That's what we're trying to prevent by really controlling the transmission. So how do we decrease the transmission? How do we flatten that curve? And specifically, we're going to talk about how do we do that so that we can get back on our bikes. And it really is not that complicated. We know now how to do it. Early on last year, we did not know exactly what it was going to take, and now we do. So we'll talk about these one at a time, but avoid crowded indoor spaces, use a mask and distance to prevent that close contact, limit exposure time, good hand hygiene, just in case there is that possibility of surface contamination. And then I want to talk about vaccination because I think that really is our way out of this. So look, the best way to decrease transmission is to go outside. There is almost no transmission in normal outside activity. We have seen this over and over and over again in outbreak studies, that the transmission is much easier in enclosed spaces rather than outdoors. It's about 19 to 20 times more easy to transmit that in an enclosed indoor space. And we've seen this. I could detail for you literally dozens of papers that say basically this exact same thing. In one very carefully done study in China with over 1,200 cases, there was only one outbreak that involved 2 patients that occurred outside. And this was people standing very close for over 15 minutes, close together, talking in a park, and they transmitted the virus one to another. And in Japan recently, there was a report for road running races where they did over 787 races and had almost 700,000 participants between the officials and the participants, and they had only one case that came from that. So again, outside, as long as you're being careful, outside seems to be very, very safe. That is good news for us that love cycling, right? And that's why when I haven't seen a single case that has been transmitted on the bike outdoors, and I've looked and looked and looked. If anyone knows of anyone, put it in the chat, because I'd like to hear exactly how it happened. But I haven't heard any cases. Okay, so outside is key, and then it's simple: mask, distance, and time. Since this is mostly droplet spread, these 3 things are key. Masks reduced the spread of particles by 75 to 95%. These studies have been done over and over and over again. Again, early on, even Dr. Fauci wasn't sure if masks were going to help. Now we know. And then And then these things can add together. So yes, if you wear a mask, that's good. If you wear a mask and have distance, that's even better. It has an additive effect. So distance greater than 6 feet reduces particles to near zero. And I'll tell you, I do this every single day when I go to work. You have to understand, I go to work in the place where the sick people live. I've taken care of COVID patients hundreds and hundreds of times this year. And this is what I do. I wear a mask and I stay more than 6 feet away unless I have to get close to that patient. And I promise you, I didn't get COVID-19 despite that exposure to hundreds and hundreds of COVID positive patients at the time when they were most infectious. And I know that because I did antibody tests and I was tested multiple times throughout the year. So masks and distance really, really works. And then longer exposure time does increase the risk. And it's an area under the curve phenomenon. Think about it like a sunburn. It's not like if you walk outside and you're exposed to that UV radiation, you have an instant sunburn, but the longer you spend there, the more likely you are to get that sunburn, especially if you don't do anything to reduce it. If you reduce your exposure to the UV light, then you reduce your risk of sunburn. And this any respiratory virus is almost the exact same thing. So think about it like a sunburn. If you can do mask, distance, and decrease time, you can really limit the likelihood you're gonna get it. And that's good news for us in the cycling world. All right, so again, I want to go through a case report. This was a fitness instructor. There were 2 fitness instructors that got it at this one gym, and they were doing 1-hour indoor classes. When the instructor was masked, even though a 1-hour indoor class, this is a pretty high risk situation, there were no cases. The attack rate was 0. No one else in that class got it. When the instructor was not masked, there were lots of cases with anywhere from 25 to 100% attack rate. In a couple of those classes, like a yoga class or an indoor cycling class, everybody in the class got it. So again, that tells me these things add up to reduce the transmission. And so if you can think about mask, distance, and time, you will limit your likelihood. And that's what we need to do when we're trying to put on cycling group rides and events. All right, let's talk about what we think is the best way to decrease transmission, and that's vaccination. So, hey, Kevin, if you want to put out a poll,
Yeah, let's try this.
I'd be interested in is how many people know of somebody, basically how many people would get the vaccine if you could. So just a simple yes or no. No vaccine shaming here.
This is totally anonymous too. So.
Good. I'm interested. I will tell you that in my hospital, 30% of the doctors and nurses say they will not get the vaccine right now. They've had the vaccine. Offered to them, and they won't do it. So it's interesting. So good, excellent. I am preaching to the vaccine choir, but I want to arm you with a little bit of info just in case you have friends or family members that are nervous about the vaccine. I want to arm you with some info that you can hopefully talk to them. All right. Full disclosure, I think that the vaccine is our best way out of this thing. And so I'm going to encourage people to get it. Let's talk about how a vaccine typically gets approved and what happened here. Because one of the things I hear from people is that maybe this was too fast. Maybe they cut some corners on safety and we don't know how safe this vaccine is. So let me just walk you through typical vaccine production and what happened this time. So the key thing is that there's really 5 phases of vaccine development. One is preclinical. That's when we're doing animal studies. We're trying to understand the nature of the infection and the immune response to it. Phase 1 is when you think, okay, we understand how that works now. Now let's see if we can create a vaccine and look at its safety and try to find the right dose of the vaccine to do. And you do this with a very small number of patients, 10 to 20. If that's successful and you find the right dose, now you go on to phase 2 where you have hundreds of patients and you're really looking at the immune response. Do you make good antibodies? Do you make good T cells? Do we have that correct immune response to this? And if that works, then you can go on to very large placebo-controlled studies where you have 30 to 70,000 patients. Some get the vaccine, some get a placebo, and you're really looking at what is the efficacy at preventing disease in phase 3. Once it gets approved, now you go into phase 4. When you make a vaccine, you are never finished studying it. So we have seen this with this vaccine as well. Recent report came out of over 14 million vaccination events, looking at overall safety. So that post-approval monitoring goes on for a long time. All right, so that's the way vaccines are developed, and here's the way it typically works. In that preclinical phase, the typical time is about 10 to 15 years to do that, and then it takes another 5 to 10 years to go from phase 1 to phase 3 and approval. And so overall, the typical thinking is it takes 20 years and $1 billion to make a vaccine. So you might ask, how did we do this in less than a year? And the question I want to really get at is, were there safety corners cut to create this vaccine? So here's how we did it. We did it with Operation Warp Speed. The US government came up with a plan to de-risk vaccine development for these companies. And they basically said, we will pay for your phase 3 trials. That $1 billion, don't worry, we got this. And while you're doing that phase 3 trial, we don't even know if it's going to work, but we want you to be gearing up to mass produce it while you're there, and we'll pay for that too. This allowed these companies to test likely candidates risk-free. So they had it all paid for, and they knew that they had a market to sell it. And so they didn't have to cut any safety corners because it was de-risked for them. So when people ask me, how did we create this vaccine so quickly? I say there's really one thing that we did, and that's money. You could have cut corners on safety, but the money was so available to these companies that they didn't have to. And if you look at the amount of money that the US government and other governments spent on this, it is impressive. So this number over here, this is 2 billion. These are the different vaccine candidates. And this is how much they got. So Moderna got over $2 billion from the US government. Pfizer got almost that much. Johnson & Johnson, AstraZeneca. And frankly, this was largely funded by the US. So again, the way we developed this vaccine was not by cutting safety corners, but by funding it the right way. And I'm proud of our government for doing that. You've heard a lot about the vaccine rollout, and a lot of it is very pessimistic. A lot of it is I think, not entirely accurate. So yes, there have been some problems, but in fact, we have done, I think, an excellent job in this country getting the vaccine out. I wish we could have given more doses already, but it's hard to give doses that haven't even been produced yet. As these companies are ramping up the production, we're going to see it happen faster and faster. As of yesterday, 70.4 million doses were given in the US since December 14th, and over 234 million worldwide. So we've done about a third of the total vaccine delivery of the globe. The U.S. Has been averaging over 1.5 million shots per day, and the plan is to get that up to 3 million by the end of March. And so far, 14.5% of the U.S. population has had at least one shot, with over 50% of people aged 65 already being vaccinated, which is fantastic. That we see that those higher age brackets are where we see almost all of the severe disease. And so having people over 65 vaccinated is going to really control those hospitalizations. Now, anytime we're talking about vaccines, we have to talk about the variants. And there's 4 variants that are getting a lot of press right now: the UK, South Africa, Brazil, and a new one that just came out last week in New York. All of these variants have changes in the spike protein, that one that controls the binding to our cells and controls some of the transmission, and is also the best target for antibodies that your body makes in response to the vaccine or to a natural infection. First of all, I want to say variants in coronavirus are nothing new. This has been happening since the absolute earliest days of this pandemic. This is a look at all of the different strains that were here. I did this for a talk back in May, so a long time ago, and you can see there were already thousands, tens of thousands of different variants already. And you can see the variants were starting as soon as we identified the virus. There were already multiple variants out there. What's happened now is that these variants have changes in the spike protein that actually help it bind to human cells better. The UK variant has been studied pretty closely, and what we saw there was an increase in transmission. So the R naught at around the time this variant came out was about 1.1 in the UK, so spreading. And the R naught for the variant form increased that to about 1.4. So it does seem to spread a little bit better. And that change in that spike protein means that the antibodies generated from the vaccine don't work quite as well. We've studied this already. We know that the antibodies generated by the vaccine have about 3.5 times less affinity for the UK variant protein. But the key thing is the antibodies are so high from vaccination that even if you decrease it by 3.5-fold, it's still incredibly good at stopping that infection. So we know from real data that the vaccines we have out right now are very effective at stopping the UK variant. The South African variant even has more changes, and the antibodies seem to be even a little bit less effective. But the key thing, and I want everybody to remember this, the vaccine is essentially 100% effective at stopping severe disease, even in the South African variant. There were no hospitalizations or deaths in people that had been vaccinated. So some people do get a mild infection. They may even be able to spread the virus, but no hospitalizations or deaths on the South African variant for people that have been vaccinated. And Moderna and the other ones have already started testing variant-specific vaccines. So in that case, what they do is they take the spike protein from the South African variant with its changes, and they use that to make their vaccine. So now you've got specific antibodies that are made for that. So yes, the variants are something we need to watch. Yes, it's concerning, but we right now we have a lot of good news about how effective the vaccine is for these variants. All right, so we've talked a little bit about the basics of the virus, how it's transmitted, how we can stop the transmission, and why I think vaccination is so important. Let's get back to cycling, right? That's why we're all here. So a couple of quick questions I want to go through. Is cycling safe? How are we going to get back to group rides and events? And then when are things going to get back to normal? And then part of that is I want to show you how to get location-specific information. So if you're planning an event or you're thinking about going to something, you can look at what is happening with coronavirus at that very specific location. So first of all, is cycling safe? And I want to say there's no way to get to zero risk anymore. And we should be used to that in cycling, right? It never was a zero risk sport. There's always things happening, crashes and minor injuries, but we are used to mitigating risk with cycling, right? We wear helmets, we try to drive safely, we try to obey traffic rules. So we're used to risk mitigation tactics to make cycling safer. Now we just have to layer on, ways to mitigate the risk of transmitting the virus or catching it from cycling. In general, outdoor cycling is very safe. Like I said, I haven't seen any cases that I can tie back to a cyclist transmitting to another cyclist while on the bike outside. When we talk to local health departments across the country, we hear this over and over and over again. Outdoor events, as long as they're not too crowded, seem to be very, very safe. Outdoor sports seem to be very, very safe. It's the off-bike activities that are the riskiest. These are the things you need to think about. So it's like, how did you get there? Did you have to, take public transportation or go to an airport? That's where the risk is. What did you do before and after the ride? Coffee shops, bars, pizza parties, all that kind of stuff. That's where the risk seems to be. The bike itself seems to be safe. What about group rides? We've put out some, group ride suggestions for at USA Cycling. I'll show you how to get to those. In general, solo rides are still going to be safer than group rides. We know that. But in areas that have very low transmission of COVID-19, we think small group rides with close contacts, people that are sort of in your bubble, are likely safe. I spent the summer riding with my son in the pandemic. We were living together, right? And so going out for a bike ride was not the riskiest contact that we would have. So people that you work with or you have close contacts with already, that's likely safe. Small group rides with individuals other than close contacts can be risky, but you can mitigate that risk with some simple behavioral changes. And as of right now, large group rides with a lot of people that you don't know, we think are still difficult to recommend, certainly in areas that are having community spread of the virus, which is most places in the country now. So how do we mitigate those risks? And it's really two simple things. You got to focus on who is riding and how you can do the ride to reduce the risks. So who is riding? You want everybody to be symptom free for at least 14 days, right? So you ask them, when you're getting to the group rides, anybody here got any symptoms, fever, chill, fatigue, cough, upper respiratory symptoms, body aches. The days of being tough and going to work or going to group ride when you're feeling sick, those days are over, right? If you're sick, stay home. You owe it to your friends and to the people you're going to come in contact with to not spread this virus around. And then I would say go one step further, which is look at risk factors. So people who have just come back from travel with a place with a lot of spread of the virus, or known contact with known or suspected COVID patients. Again, those people should be 14 days out of that contact before you want to ride with them. If you can do those things, then I think you can feel pretty safe. Now there is always that risk that people are in the asymptomatic or pre-symptomatic area, and they could still be spreading the virus. But again, we're not going to get to zero risk, so we're just trying to mitigate it. So I think if you're having group rides, ask people that. And then how do you do the ride, in a way to make it safe when you're doing these larger rides with people that you may not know, people that aren't in your personal bubble. We think wearing a mask on the bike is not too much to ask. So you can wear a cloth mask. It definitely prevents droplet spread. It's not intended to filter all the air, just contain droplets. And my suggestion is bring a spare, because if it is a long ride, it gets sweaty, then the mask can get uncomfortable and you can swap it up. Do things to reduce the droplets. If you have to sneeze, cough, or blow your nose or something like that, get to the back of the group, make sure no one's in your slipstream and you can do it. And then, bring hand sanitizer. So after that, you can wash your hands. It's fairly easy to do. And then distance. We recommend ride side by side where the wind is blowing everything behind you, or more than 20 feet behind. The honest truth is nobody knows. Nobody knows what's safe. Again, we haven't seen transmission at high levels from these kinds of activities. It's a guess. 20 feet behind seems safe, but really there's not good science on this. Farther away, the better. Side by side or more than 20 feet is what we recommend if you're riding with people that you don't know very well. If you're riding with people that are close contacts, you don't need to do that. So solo rides are safer than group rides. Pay really close attention to the off-bike activity, stopping and going in places, what you do before and after the ride. That's much more likely to transmit the virus. And change the group ride to reduce the risk that you're riding with someone who can spread the virus. And that's who's on the ride and how are you doing it. What about events? Look, we're going to see racing continue. Professional races are using this bubble concept, where they have the resources to test. This is straight from the UCI's COVID racing Bible. Their font is a little odd, but this just shows we do a PCR based test at day 6 before the event and day 3, and then once you're in that bubble, nobody leaves. So you're not going in and out of the bubble, and they are serious about it. And you want to talk about serious sort of mask policing? It is real. And then if you're doing multiple races, they test again 10 days later. So everybody's being tested while they're in that bubble. The whole idea is make sure everybody in that bubble doesn't have the virus, and then you can ride and race. Hard to do for regular events. So amateur events need to make sure that the viral transmission in the area is low, and do some things to make the racing safe. And most of that is concentrated on the off-bike activities. We have a bunch of resources at USA Cycling. If you go to the website, go to event organizers, and there's COVID-19 event resources there, and you can get all of our guidelines, our protocols. We have a specific tool that we've made up to look at the risk and specific tools to minimize that. If you're trying to put on an event or anything like that, you're probably going to have to talk to the public health department in that area to get permitting. And these resources will really help. When you go through those spreadsheets and go through that stuff, it really helps you think about how risky is your event, and have you done everything that you can minimize those risks. So it's actually helpful. Then I want to just show you guys how to access some detailed local information. So let me share another screen. What I'm going to do is I'm going to go to, this is the El Paso County Health Department website. El Paso County, Colorado is where I live. But in general, these data tools have been shared widely. Almost every health department that I've looked at has a dashboard very similar to this. So you can see here, we're at the COVID-19 page. You can go to this area that says COVID-19 data dashboard. And it's going to pull up a series of pages. The first one is just a quick summary. It tells you where we are in the dial. So we're at a yellow. We went from orange to yellow a couple of weeks ago, and that has some meaning as far as how many people can be in restaurants and all that kind of stuff. So again, just a really nice snapshot, but you can actually go further and get more data. This is the one I like to look at, which is the case count, and you can see we were in trouble back in November, December, and I'll tell you the ICU was full. We had almost no excess capacity, but things started to calm down pretty quickly, and the case count dropped really dramatically, and then has stabilized, and it's right at this about 130 cases per 100,000 of population. And so if you're thinking about going to an event or putting on an event, you can look at this and say, you would not want to be doing an event at this time, right? The hospitals are full. It's not responsible to bring people into this community and to do something, an event where people might get hurt and need to go to the hospital when that hospital is overwhelmed. But again, if you're down here at these very low numbers, it's probably pretty safe. And then you can also look at things like average positivity. Again, if everybody who's getting tested is coming up positive, it probably means that the spread is happening. You can see we're having declining positivity rates. So again, if you're thinking about putting on an event or you're thinking about going to an event, the local health department, wherever that is, should have good info like this, and you can. It's relatively easy to access, and it'll help you sort of keep track of everything. All right, let me just share one more screen. So one of the questions I get asked a lot is how, basically, help us predict what's going to happen. So can you guys see that? Good. All right. So what's going to happen? When are things going to get back to normal? Anyone who tries to predict things in the face of this pandemic is an idiot, and you're probably going to be wrong. So I'm an idiot, and I might be wrong. You ready? I think that the future is looking bright. I think if we project out into this summer and beyond, I think we have a lot of reason for optimism. And let's just go through the numbers really quick. We have about 30 million known cases in the US. So those are people who have had the virus, and most of whom have recovered. And we know that most people who recover have at least intermediate term immunity to the virus. They are not easily reinfected. There may be a few, 1 in a million or so, that get reinfected, but it does not seem to be a very common thing. So 30 million, it's probably really about 3 to 5 times that. So maybe there's about 100 million people in this country that are now immune to reinfection because they've already had the virus. Add to that, we're vaccinating people at a rate of 1.5 million doses per day. And we've had 14% of the country has had at least 1 dose, which does offer some pretty good protection. So add those together. Maybe we've got a third of people that have natural immunity, 14% of people that have vaccine-mediated immunity, and that number is going up and up and up. If we can get to 3 million doses a day over the course of a couple months, that's 45, 50 million people who will be fully vaccinated. Those things add together to mean that there's less susceptibility to infection. And what we know is, even if we get to a population immunity of 50 to 60%, what that does is turns the effective reproduction number, that's what this is, it turns the dial down. So even if we're at, say, 2 normally, at an immunity, population immunity of 60%, that number becomes less than 1. And when it becomes less than 1, you start to see the numbers really decline fairly quickly. I think we can expect to see the number of people that have immunity increasing through the spring and into the summer. And I think things could be coming back to relatively normal. We have to watch the variants, that this is a very changeable virus. There's a lot of things that we can watch, but I think that there is some reason for optimism. Okay, I think I have left a few minutes, almost 15 minutes, for questions.
Yeah, that was great. Thank you so much, Dr. Roshon. This is really great. There's been
Too sciencey?
No, wonderful, wonderful. Yeah, overwhelmingly positive reviews. Yeah, a few great questions, lots of chatting going back and forth, people sharing resources. There was early on a question about cycling during periods of dangerous air quality due to other things like forest fires, oil drilling. Do you have anything to say about that?
Yeah, I think you have to pay attention to that, and when you think about any outdoor activity and those kind of things, some people, it doesn't seem to bother them, but almost anyone. But we've had forest fires here. You go out and you hear people coughing all the time. So yeah, most of the time there's no reason to do that. Again, it's a little bit individual, and again, you got to think about how long you're being exposed to those things. So maybe that if the air quality is only mildly bad and you want to go out for a short ride, it's fine. Some people, again, very, very sensitive to that.
Great. One that just came in that I think is really interesting. What about group rides among older riders that they're all vaccinated and fully? Any particular things to say about that?
Yeah. Okay. So right now the party line is we don't know if vaccination will protect people from being able to spread the virus. That's the party line. I'll tell you what we are finding in the real world experiment. Again, there's been hundreds of millions of doses of this vaccine done. People that get the vaccine are very, very well protected. I think you can consider vaccinated people as unable to spread the virus. Weird things are going to happen, so again, if somebody says, yeah, I got the vaccine 2 months ago and now I've got a fever of 104 and I'm coughing like crazy and I was just around a whole bunch of COVID positive people last week. Well, okay, maybe consider that person as potentially infectious. But I think in general, the data that we've seen, the vaccine offers incredibly good protection. It's not perfect, but really good.
Yeah. I'm putting you on the spot, but a lot of people were wondering if they could share some of your slides specifically with members of their bike club. So if you could provide that, we can send it out. Or
absolutely.
Of it, we'd appreciate it. Do you have suggestions for mass starts and rest stops, like any guidance for those mechanics of the group ride?
Yeah. Again, if you go to the USA Cycling website, we've got a lot of this stuff on there. We've suggested ways that you can change the way you do packet pickup so that people aren't crowded. And again, it's back to that, that sunburn analogy. You're going to be close to people, but just don't spend too much time there. Same for inside. That's why you want to bring a mask and an extra mask. If you have to stop and get water or something like that, you can wear your mask when you're around members of the general public. Milling about in close contact for a long time before the ride, probably not a great idea. Again, anything you can do to control who is there at the ride and make sure that they're low risk, that's probably the best thing you can do.
So a follow-up question on those already vaccinated persons who have a known exposure, should they refrain from riding in case there's a spread going on? I think a lot of these answers are just err on the side of caution. But
Yeah, no, you're absolutely right. The cautious answer is if you had a known exposure, even if you're vaccinated, sort of semi-quarantine or self-quarantine if you can. It's a relatively easy thing to do. If you don't get symptoms within about 10 days, you're probably safe. Again, my gut is, as we're going to find as we get more and more data, is that for vaccinated people, if it's a low risk type of exposure, you're probably safe. High risk exposures, and I'm thinking about prolonged indoor contact, like riding in a car for 2 hours with someone, and then you find that they were positive for COVID. Those kind of high risk things, you probably need to be a little bit more careful about.
great. One that just came in, and there's a lot of information out about vaccines, and they're always changing. This person, I've been told that the vaccine is only good for 3 months. Is this true?
Again, the party line is we don't know how long the immunity will last. So I think that's where that 3-month thing came from. There is no reason to expect that immunity is going to wane in 3 months. There's just no reason for that. We see for the vaccines that are out there, the level of antibody production is so high that I think it's predicted to last for a very long time. We don't know, right? I mean, the first vaccines were given, starting in December, so it'll take us a while to get that kind of data. But just looking at the science behind the vaccine, looking at the results we can get, I think that's just an overly cautious approach.
Great. I like this one. Is there a type of cloth mask you recommend for outdoor cycling?
Yeah, what I like are the like ones you get at the hospital, the surgical masks, because they're made. First of all, they're light. You can breathe them a little bit easier. When they're made, they have a little bit of a charge to them, so that the particles actually stick to it. So you can make the hole a little bit bigger, so it's not as restricting on respiration, but the virus can't get through. So those are the ones that I like, and I find that the sort of t-shirt style stuff is hard to ride with for me. So that would be my suggestion. I'll tell you that you don't need the N95s, the really big respirator masks. Those don't seem to be required for this kind of stuff. What I tell people is, if you're going somewhere and you're getting on a plane or something where you can't control who you're around, have one of those in your back pocket so you can put it on if you get into a situation that seems higher risk. But in general, those standard surgical masks are the best. Anything is better than nothing. I know that there's some people who say that neck gaiters and stuff might actually increase the spread of the virus. I've looked at those studies, and I don't think that that's true. Anything is probably better than nothing. Kevin, what's the answer to people when you asked them when they were planning events?
Yeah, thanks. Going back to the poll. Here, I'll share the results. I like these. My bike club is planning for rides. 37% of you said immediately. I mean, you're planning now, but spring and summer is fairly equal, and then some not until fall, and some not planning at all. And I mean, we'll be clear. Not all bike clubs are going to come out the other end of this, right? I mean, it'll take some work to get the wheels back turning.
Well, I think this just shows that we can't get the risk to zero, and there's going to be. It's fine for people to have different risk assessments. It's fine. And again, if you're a high risk individual, you think if I get the virus, then it's gonna go badly. Then you're going to need to be more conservative on that kind of stuff. I think this, it looks like 44% of people said spring. If you add those up, that's about 80% of people are going to be happy to have rides by summer, which I think is a reasonable thing. Now, got to got to keep watching, right? So look at the local resources, watch what's happening with the virus, and if you see the cases are taking off and the hospitals are getting full, then just be ready to change.
Right. And it looks like most clubs were on hiatus as of last fall, but the definition of that is pretty loose, right? I mean, clubs can be operating, 4-person rides or informal rides. So yeah, we've seen here at the League, we've seen a pretty wide spectrum of guidelines and or event planning. Oh, here's a good one. Does a soggy mask, the sound of that is gross, does a mask still stop droplets?
Again, it's probably better than nothing. It's but probably not as effective as a dry mask. So that's why I tell people, bring two or three if it's a long ride, something you can swap out. And some people talk about, like, if you have to stop and fix a flat or go into a gas station or something like that, that's when you pull out your fresh mask and make sure that because you don't know who you're going to come in contact with.
Yeah, this is a good suggestion to put it in a Ziploc. Yeah, I like that. Yeah. And any last minute questions? Otherwise, we will shut down this meeting. We're going to go have a 15-minute break. I see that my speakers for the next session are already here, so go right back into the Zoom link, and we'll resume at 1:15. Dr. Roshon, thank you so much. This was great information. There will be a recording of this session, of course, as with every session at the National Bike Summit, posted on Whova. So watch them over and over again. There's so much great content here, and we're all so grateful to have you here. And thank you to SRAM once again for underwriting today. Yeah, have a wonderful National Bike Summit. Thank you, Doctor.
Thanks, guys.